In the next 5 years, proteomics has the potential to change the way we care for cancer patients. What we're going to see is the routine use of this and the routine use of decisions that wouldn't have been made possible before. When a woman comes back to us with recurrent or refractory disease, that means that frontline care hasn't worked out. And so we need to find different molecular levels to try to use to diagnose that new cancer. So one of the biggest challenges today in treating difficult cancers like ovarian or endometrial cancer is that these cancers are very different from patient to patient. And what we need to be able to do is we need to bring personalization to that, which means that we need to bring individual information, individual decisions to that patient. So proteomics is becoming increasingly important in the cancer narrative because we understand that drugs don't target genes. Drugs target proteins. What proteomics is allowing us to do, in addition to genomics, is giving more information about options for patients. Now, in our health system, we do something called a molecular tumor board, where we bring physicians like oncologists, surgeons, radiologists, pathologists, but the molecular is where we bring science to that table so that we can now basically discuss best options based on clinical and molecular data and give the provider the best set of information to make decisions about the next stage of that cancer patient's journey. Now, in our experience, we ran a feasibility trial using proteomic return of data in our molecular tumor board, and we enrolled 200 patients. And at the end of the day, when we were done with this trial, we were very surprised to see that proteomic return of data led to a 54% change of plan for each one of those cancer patients enrolled in the trial. We're in sort of the anecdotal age of proteomic return of data, much like genomics was 15 or 20 years ago. This has changed people's lives. We've got anecdotes, for example, a triple negative breast cancer patient in our study. She had no opportunities left for her care. She had little kids in her family. She was 38 years old. We found an activated signal that allowed us to have an inclination that this might be an opportunity for her. They made the decision to put her on a HER2 targeted therapy, and that completely resolved her cancer in 4 to 5 cycles of care. So we've got these sort of anecdotes that raise the hackles on the back of your head, that make you know that we're there. We just need to make this democratizable and to make this standardizable.